aspect. We are going to equally be reviewing the 4 pre-delivery questions, which are very important to be able to know whether we have enough equipment and enough human resource to receive the baby. And lastly, we are going to be looking at our equipment check by using the dry warm air rule. The transition from intrauterine extrauterine line. This phase is very critical because intrauterine, the babies, the fetal lungs are liquid filled. So when the fetal now transits from when the neonate transits from the fetal to neonatal line, he should be able to expel the fluid in the lungs and replace that fluid with oxygen. How does this come about? During vaginal delivery, there is a little pressure that is exerted naturally. There's a little pressure that is exerted on the chest of the neonate, which the pressure of 25 to 30 centimeters of water, which permits the fluid, part of the fluid in the lungs to be expelled. And the remaining fluid still in the lungs is being drained by the pulmonary lymphatic system. When this fluid has left the lung, it does not mean the lung is uncollapsed. The lung still remains collapsed and unaerated. For the lung to be aerated and for the lung to start expansion, the baby on its own produces a negative pressure of about 40 to 80 millimeters of water to be able to expand its lungs and take in oxygen, thereby beginning respiration. Please, let's take note of this pressure, 40 to 80 centimeters of water, because it is very important for us reanimators. Because when we are delivering a positive pressure to the patient during resuscitation, we have to exceed the baseline pressure that the neonate already produces. So when we are starting to deliver pressure to the baby, we are starting at least 8 centimeters of water. But please, while delivering pressure to neonate, we should be mindful of the risk of pneumothorax. The baby is able to maintain a functional residual capacity. We all know it is important. It's a natural positive end expiratory pressure, the natural peak that we all produce. So the baby is able to maintain his alveolar open and avoid atelectasis. And lastly, by the cord clamping, there is a vasoconstriction at the umbilical arteries, which causes an increase in the systematic arterial pressure. This increase in the systematic arterial pressure is important for the neonate because it permits the lungs to be perfectly circulated with oxygen carried back, perfectly circulated with the blood. And the oxygen now is being carried by this same blood and transported to the whole body. At birth, there is what they call an asphyxial stress, and it's very normal in neonates. It's generally mild to moderate asphyxial stress that the baby is not able to breathe here and there. But it's very mild, it's very brief, just 4 to 5 seconds. This stress is usually compensated by the neonate. But in case this stress is not compensated, or the baby is not able to pick up the breathing pace as fast as he should, then we need to come in and help him pick it up. We need to come in and resuscitate him. So here we are going to be seeing some indications of reanimation in neonates. Naturally, at birth, there's what we call primary apnea. This is just a cessation of breathing for a few seconds, and it is a sign of distress in neonates. Generally, after stimulus, by rubbing the back, flicking the feet, the neonate is able to pick up on his own and start breathing. But then, if after stimulation, that is after warming, rubbing of back, flicking of feet, the neonate is not able to pick up breathing on its own, then we refer to a secondary apnea. And in the case we have a secondary apnea, then we need to go in with our resuscitation to aid the neonate breathe on its own. Generally, what we do at birth is we take the ABGA score. We note the baby based on the physical appearances, activity, muscle tone, crying, that is the heart rate. That is how we rate the child at birth. But it should be noted that these physical characteristics do not permit us to distinguish whether the apnea we are seeing is primary or secondary. To be able to distinguish if the apnea we are actually seeing is primary or secondary, we need the simulation test. That is when the baby is born and is unable to breathe. We warm the baby, we flip the lap, flip the feet. And if after this simulation, the baby is able to pick up breathing on its own, we know that, okay, the baby was going through what we call primary apnea. But if after the stimulation, the baby is still not able to pick up breathing on its own, it induces that it's a secondary apnea and we go in with our resuscitation techniques. Before that, we always need to prepare to receive the baby. You know the common saying, failure to prepare is very to fail. So to aid us in our preparation, we have these 4 very important questions we should always ask ourselves. Firstly, what is the expected gestational age? As I told you, these questions will help us prepare not only on the equipment side, but on the human resource side. If the baby is a child baby, you know, we are not going to need too much sophisticated equipment. If the baby is preterm, that is a prenatal baby, a premature baby, we are going to be using a plastic wrapping, able to give the baby enough warmth and to prevent the easy diffusion of his own, warmth that is. If the baby is post-term, we could be maybe standing a risk of maybe seeing the baby maybe into stress, maybe from meconium or something, and it will help us prepare our equipment to that effect. The next question we ask is, what is the meconic fluid color? Is it clear? Is it dark? Is it greenish? This helps us tell us how the baby is already intrauterus. Is the baby okay? Is the baby in some sort of distress? And it helps us prepare the equipment in that regard. Thirdly, we are asking ourselves, how many babies are we expecting? If we are expecting 1 child, we will not need as many human resources or as many people to receive the baby as if there are 2 or 3 or 4 or more children we are expecting. The last question we ask ourselves is, are there any additional risk factors, maybe coming from the mom, for example, gestational diabetes? We know children coming out from a mother who is diabetic, normally they are very weak, have to overstimulate, have to resuscitate. Babies with already some comorbidities on themselves, but now with our with the involvement that we can actually see if the baby has some abnormalities or not, and we can now prepare in that regard. Our equipment check. How do we check our equipment? Because you know, even when we are in anesthesia, when we are opening our theater, we have a checklist. It's the same for delivery. We equally have checklists in delivery. And here, sorry, the acronym we use is, or the rule we use is the dry warm air rule. That is to check for things to warm the baby up. We have the radiant warmer, we have warm towels, we have a hat, we have etc. We have the sock, the baby sock. We then need that's for the warm and the dry. Now, what about the air? For the air, we need a clear airway. How do you make sure the baby's airways are clear? We need suction. We have what we call the box syringe. We have normal suction machines. But mind you, using suction machines, to be very, very careful. As I said, be mindful of the risk of having a pneumotor. We equally have to auscultate to check whether our baby's heart rate is normal or not. That means we use our stethoscope. We have the ventilatory equipment. Notably, we use the T-piece resuscitator, or we use the back valve mark, or we can use our normal ample bags. We equally have oxygen. It's very clear to be able to deliver oxygen to the patient, to the baby. Up next, we are going to be looking at the neonatal resuscitation program algorithm. This algorithm was put in place to facilitate neonatal resuscitation, and it's very easy. It's something we do in less than 30 minutes. In less than 30 seconds, sorry. Very easy, very consistent. In this algorithm, we have what we do in the first 30 seconds. That is the initial steps. We always assess. After every step, we always assess for the pulse and the breathing, checking what we are doing is working or not. We have the positive pressure ventilation technique, how to deliver positive pressure ventilation. And lastly, we have the acronym Mr. SOFA. This acronym is the corrective steps for the failure of positive pressure ventilation, I shall be explaining for them. The initial steps. So when we receive our babies, we ask ourselves 3 questions. Firstly, is the baby at term of gestation? Secondly, does the baby have a good tone? Thirdly, is the baby breathing or crying? It just concludes, it's all summarized in our ABDAS forum. From the ABDAS forum, you can know most of these answers. If to all these 3 questions, you have positive answer, that is, the baby is at a good term of gestation, the baby has a good tone, and the baby is either crying or breathing, then it's fine. This baby can be cleaned, dressed up, and put to the mother. But if to any of these 3 questions, if the baby does not have a good gestation, the baby does not have a good tone, or isn't breathing or crying properly, this baby is a baby that we have to resuscitate. Now, if to any of these questions the answer is no, we go to the next phase. Firstly, we warm. We warm the baby, that is, we dry the baby. And please take note, the towel you are using to clean the baby up is fluid. Should not be used to wrap the baby up, because this hypothermia is a very big risk of bradypnea. Secondly, we have to position the airway. And as we say, we generally do by extending the baby's head when we are doing our suctioning or anything. No, the baby's head should be put in a neutral position. That is, the head and the thorax should be in alignment. That is the proper positioning for neonatal resuscitation. We also have to clear the secretion, that is, we use our bulb syringe, take out any secretion from the mouth and the nostrils to permit the baby breathe. And lastly, we have the drying and the stimulation. I told you stimulation is rubbing the back, flicking the toes, just to get the baby to react. Then next, we have the assessment of the pulse and the breathing. How is this done? We count the baby's breath per every 6 seconds, because we don't have enough time to say we do it for 1 minute. You count how many breaths does the baby have in 6 seconds. Then we multiply that by 10 to have the breath per minute. So if that child has a normal breathing, that is a heart rate of more than 100 beats per minute, that child is good to go. You dress the child up and you take to the mother. But if that child has less than 100 beats per minute of heart rate, this child needs additional resuscitation. That is, the baby either is gasping, that is, the baby has irregular breath, or has anagonal breathings, or if the baby is in complete apnea, the baby is not breathing at all, we now go to what we call the positive pressure ventilation. We aid the baby with additional oxygen. Positive pressure ventilation. This is the most important step in neonatal resuscitation. And the indications, as we already said, it's a heart rate less than 100 beats per minute. It's a baby who is in apnea or a baby who has gasping breaths. How do we do it? We administer a rate of 40 to 60 breaths per minute to the baby. How is it done? I am holding my T-piece resuscitator, and this is how I deliver the breath to the child. Breath, 2, 3, breath, 2, 3, breath, 2, 3, breath. That is how it is done, to be able to have a heart rate of heart rate of 40 to 60. This is how to deliver 40 to 60 breaths per minute to the neonate. And if the baby is a baby who is at term, the oxygen delivered is at 21%. That is, the FiO2 is at 21%. But if the baby is preterm, that is, we need more oxygen, we are going to increase the oxygen delivered from 21 to 30 degrees to 30% of oxygen delivered. Then, if we have done this for 30 seconds, what do? We assess the breath and we assess the heart rate. If the baby still do not have a heart rate greater than 100%, 100 beats per minute, or if the baby does not still pick up breathing on his own, we go to the next phase of the neonatal resuscitation algorithm. We said we use the acronym Mr. SOPA. Very easy. M stands for the max adjustment. Maybe the reason why the baby is not receiving as much bread as you are delivering to him is because the mask is not of the right size. So what do? We change the mask to the exact size the baby is. To the exact size the baby yes, if or have. Ow! That is reposition airway. I told you that one mistake we do. Sorry. One mistake we do during resuscitation is that we don't position the baby adequately. Sometimes we hyperextend the head, blocking the airways, thinking we are actually opening, whereas it's wrong. So what do? We put the baby in the appropriate position. I told you it's a neutral position. The ears and the chest should be aligned. Next, we have S. The S is just for suctioning. That is suction the mouth, suction the nostril. Clear the airways to vertically. We have O. O is open mouth. As we are delivering the positive pressure, the baby's mouth should be open to be able to receive it. Next, P. We increase the pressure. Maybe the pressure you are trying to deliver to the child is not enough for him. He needs more. So we increase the pressure. With our T-piece resuscitator, there is the pressure gauge. The T-piece resuscitator, which we have on our church, it comes with the pressure gauge on which can regulate the amount of pressure you are delivering to the child. And lastly, we have A. A comes in after, if you have adjusted the mask, we adjusted the baby's positioning, you have suctioned, you have opened the mouth, and you have increased the pressure. If after all this, the baby's heart rate still is not increasing, or the baby is still not breathing, what do? We go to A. Maybe the airway is not proper. We have to either intubate or use the laryngeal mask effectively to deliver the oxygen to the baby. Next, advanced intervention. These come in when the positive pressure ventilation method has failed, and when Mr. SOPA, which are the corrective steps of failure to pressure or positive pressure ventilation, are equally failed. We now go to an advanced intervention. Notably, we go to chest compressions, and we go to the administration of emergency drugs if need be. Here with the chest compressions, the indication is a baby having less than 60 beats per minute, despite 30 seconds of positive pressure ventilation. So you have administered positive pressure ventilation to your baby for 30 seconds, but the baby is still, his heart rate has still not picked up. We have to aid the heart, pump the blood to the whole body. So how is this done? We use the two-thumb method. We place our two thumbs at the lower one-third of the baby's sternum, and we encircle the rest of the chest with our hands. Turn like this. Turn like this. Turn like this. This is my baby. This is my neonate. This is my neonate. So we put our two thumbs. My hand will not go. There, you understand? This is my neonate. We put the two thumbs at the one-third of our stern, and we encircle the remaining body with the rest of our hands. Don't go back. We compress one-third of the chest diameter. If you compress half of the chest diameter, you risk breaking. The baby is very fragile. If you exert a lot of pressure on his thorax, you risk either breaking any of his ribs, causing damages to him. So we should be very mindful. Half or one-third of the chest diameter is the kind of pressure we apply on the neonate. The ratio and rate, it is a 3:1 as compared to adults. Adults know it's either a 15:1 or a 30:2. In neonate, it's a 3:1 breath compression, compression to breath ratio. And the rate is 30 compression to 30 breath, 90 compression to 30 breath, sorry. So this is how it is done. I count 1, 2, 3. I give the baby breath. 1, 2, 3. I give the baby breath. 1, 2, 3. I give the baby breath. That is how it is delivered. And this will end up at 120 breaths delivered per minute. The next up, oxygen, and the oxygen, we know we have to increase the oxygen during this exercise. We know we have to assign a particular person who is going to be handling the compressions. And we have to consider intubation if we had not intubated the baby prior. Now we come to our emergency medication, and the indication is still the same. A heart rate less than 60 breaths per minute after adequate chest compression and positive pressure ventilation administered to the neonate. The first, our main emergency drug here is ephedrine, and it's a first-line vasopressor in neonatal arrest. And it is administered either IV or sometimes if IV lines are very difficult to get, we can go intra-umbilically using the umbilical vein. And here we administer a dose of 0.1 to 0.3 milligrams per kilogram of ephedrine solution. And if there is neither an IV line nor an intra-umbilical line because of whatsoever reason, the ephedrine can also be administered intratracheally through the epinephrine can be delivered intratracheally, but the doses will be increased 0.5 to 1 milligram per kilogram. And also we have volume expanders. Here we use normal saline. Its indication is when we suspect a blood loss somewhere, or if we have any hypovolemic shock for any reason. And normally we deliver 10 milliliters per kilograms over 5 to 10 minutes. And lastly, we have the human factor. There is something we notice during emergency situations. Everybody wants to do everything at the same time. And sometimes we see two people doing the same thing, whereas there's another thing that is left undone. That is why, in the beginning, our preparatory questions are very important. When we know a baby is coming, we know the baby state, and we know the baby's SCAR, we are able to get enough personnel, the number of personnel we need to get in the baby's resuscitation. And at the beginning, roles are assigned. Firstly, we have the team leader who directs, who delegates, and who confirms actions and equally communicates with the family at the end. We have the airway manager. His role is to position the airway because he's the one performing the positive pressure ventilation and he's the one to manage intubation if need be. We have the circulator or the compressor. He's the person who does the chest compressions and is equally the person responsible for vascular accesses and for the administration of medication. Lastly, we have the time recorder. In our context, we know we cannot have 4 people on one child. Let's be realistic. But we all know that resuscitation can never be done alone. We need at least another person to aid you. So if you are two of you are enough. You have one person can act as a team leader and as an airway manager, and a second person act as a circulator or a compressor in case we need it. And the last person can be there to record the time, the administration of drugs, and monitor vital signs. Summary, these are the key takeaways from this presentation. Firstly, ventilation is the cornerstone, and the positive pressure ventilation alone is enough to resuscitate the baby. It's a powerful, impactful intervention. Secondly, we do compression only when the heart rate is less than 60 beats per minute after 10 seconds of effective positive pressure ventilation. Thirdly, ephedrine is administered only when the heart rate is less than 60 beats per minute after effective compression and effective positive pressure ventilation. The golden minutes. The complete initiation, the golden minutes include completing the initiation steps and the beginning of the positive pressure ventilation technique for 60 seconds. And lastly, in every emergency situation, please stay calm. Stay calm, be systematic, and communicate clearly. Thank you. There's a video I'm going to be telling the presentation to you. There's a little video attached to this presentation that will aid you understand better. Please, before we go, Please, before we go to the question and answer session, there's a quick quiz just to know if what has been presented was well understood by all and to help us understand better. First question, a newborn is delivered at term with one muscle tone and is not breathing. After moving the baby to the radial warmer, what is the next step you want to do? Yes, sir. According to that question, according to the answer, I already have some answers marked out to make it easy for everyone. You say, just say the A. Who else says A? B. Yes, sir. A. Yes, ma'am. A. A is correct. After the baby is born and you have warmed the baby, the next thing you do is you position the airway, you suction if necessary, you dry and you warm. Don't forget the dry, warm air rule. Next question. After performing the initial steps of the resuscitation for 30 seconds, you assess the heart rate and find that it is 30 beats per minute. What is your next action? Are you going to begin positive pressure ventilation? Are you going to administer epinephrine? Continue tactile stimulation for another 30 minutes, or are you going to start chest compression? C. Then continue tactile stimulation for another 30 minutes. Who else? 30 seconds, sorry. Who said A? A. Who else? Someone said C. Mr. Sopa. The answer is A. After you have finished your initial steps, the next thing you do is to administer positive pressure ventilation. Sometimes just by doing that, the baby picks up breathing on its own. While providing positive pressure ventilation, you notice that there is no chest rise. Following the Mr. Sopa acronym, what do you do? What does M stand for and what does R stand for? Does M stand for maintaining pressure and refueling systems, or does it stand for monitoring heart rate and rub the back, or mass adjustment, repositioning airway, or C, obviously. You adjust the mass and you reposition your airway. What is the recommended ventilation rate when providing positive pressure ventilation to a neonate? I mentioned correct, 40 to 60 breaths per minute. A baby has a heart rate of 50 breaths per minute despite 30 seconds of effective positive pressure ventilation that moves the chest. What is the next step in your algorithm? What is the next thing you do? I'm hearing B. Correct, B. You begin chest compressions. When performing chest compressions in a neonate, what is the preferred technique and the ratio of compressions to ventilation? Just talk about that. Thank you. What is the golden minute in resuscitation? A little tip was in the last slide. Somebody has said C. C is correct. The first step, that is the initial 60 seconds after birth and the start of PPV if necessary. During resuscitation, very tricky question. During resuscitation, where should the pulse oximeter probe be placed on the newborn? Very tricky question. Should it be placed on the right hand or right wrist? Should it be placed on either earlobe? Should it be placed on the left foot or the left hand? Ok, la question en français. Où est-ce que nous sommes censés placer notre saturomètre que nous connaissons? Est-ce sur la main droite? Est-ce sur les oreilles? Est-ce sur le pied gauche ou la main gauche? Les oreilles. Qui d'autre? Pardon? Oui, sur les oreilles. Ok, qui d'autre? Pied gauche. Qui d'autre? La bonne réponse est sur la main droite. Et c'est parce que la main droite reçoit directement le sang provenant de la hanche. La main droite. Chez le nouveau-né. Chez le nouveau-né. Même chez vous. Donc, sur vous, rappelez votre anatomie. Chez le nouveau-né, la main droite reçoit directement le sang provenant de la hanche. Vous pouvez le chercher. Vous pouvez le chercher. Avant, on va discuter. Next. A term baby is born, breathing well and has a good tone, but remains persistently blue. That is cyanotic in the face and in the trunk. What is the next step that you are going to do? Are you going to stimulate the baby more vigorously? Are you going to check the pulse oximetry and consider a free flow oxygen? Are you going to start PPV immediately, or are you going to administer 100% of oxygen via the mouth? Someone said D. Remember, the baby is breathing well, and the baby has a good tone. In just the face and the trunk that is blue. Remember, this test because my time is already finished. What do you say? Anyone, any answer? Sorry? D. B. Yes, who else? The person who said B is correct. You are going to check because the baby has a good tone. The baby is free. He has a good tone. And his oxygenation is okay. Heart rate is okay. The baby is just still cyanolytic at that point. You are going to check if your oxygen saturation broke. If it's well placed, I am going to allow the baby to and take it there on its own to check whether it's not the hot spot from the whole side. Because we continue with maybe PPV and then go to the next. Last question. What is the most effective way to access the neonate's heart rate during rapid resuscitations, during a rapid resuscitation scenario? Are you going to palpate the umbilical cord stamp? Are you going to auscultate with a stethoscope over the left chest? Or are you going to observe the color of mucous membrane? Are you going to be feeling the brachial pressure? Any answer? A. Are you going to be palpating the umbilical cord? Yes, B. You are going to be, that's why you need your stethoscope to auscultate the baby for heart rate. And with this, we have come to the end of our presentation. Thank you very much.